I don't know if any of you have seen this slide. This is from an ad campaign of, from Mount Sinai in New York. And to me, this says it all. This is where we're going. This is a vision of a large integrated health system in New York City that is experienced in value, and they are saying if our beds are filled, it means we've failed. So to me, that is an indicator that we are really flipping healthcare, and the road to value is straight ahead. Although we all know, as this conversation is going to tell us, it's not truly a straight line. Next slide. Recently, we did a workshop at IHI at the December conference, and we did it on exactly this topic, the universal roadmap to population health. And we set, as all of you saw when you registered for this webinar, you saw this graphic and you rated yourself on where you were in which quadrant, if you will, on this graph. And it was quite telling that people are still all over the map, if you will, and working to transform both from a risk perspective, the ability to take on risk, as well as the ability to manage manage clinical transformation in the new world of value-based care. So here, the ultimate goal is to optimize both and end up in the upper right-hand quadrant. Next slide. So in case you were wondering, here are the results based on the responses you gave us to the question we asked you in the registration for this webinar. It's quite interesting that fully a third of the people who are on the webinar today or who registered for the webinar say that they have a high readiness for risk and high clinical transformation. So I hope to get a lot of comments from those folks during the question session on the webinar. And the smallest percentage came from those with a high readiness for risk but low clinical transformation, which I think is going to be interesting, and we should get some good conversation going around that as well. And most were, another large group was in this low readiness for risk and high clinical transformation, which means that they've done a lot of work to transform, but still getting ready to actually go under capitated contracts and see how that's going to work. And then, of course, there's a significant segment that feel that they aren't ready yet. So we hope that by the end of this webinar, you'll have some good examples and lessons learned from a couple of our clients who have been down this path. Next slide. So before we go into some of those lessons learned, we're going to talk for a bit about why we're doing this and what's happening to create the need for a roadmap to population health. I'm sure based on who signed up for this webinar and how you responded to that question about where you are on the transformation, that many of you are quite familiar with this, and others may be still learning. Although I would have to say I'm sure we're all still learning, but some are at a later stage of that journey than others. So keep going, Sean, to fill out this slide. So just like Mount Sinai said, if our beds are full, we have failed. This is the reason why, that in their vision, and I think in ours and a lot of other organizations, that we are moving outside of the walls of a health system, be it a hospital or primary care practice or any facility, if you will, to a true 24/7 person-centered community, where much of healthcare, we're finally acknowledging, and health and healthcare is going to be delivered outside of those walls, and technology is going to facilitate a lot of communications, a lot of enablement of the of people themselves to better manage their health, for providers to track their patients in between visits and between episodes of care, and to be able to use analytics in a much more comprehensive, effective way on a continuous longitudinal basis versus episodic. Next slide. And anyone who's paying attention to what's going on in terms of how payment is being made and changing, you all know that it's been declared, the stake is in the ground, that value-based payment will dominate. This is just CMS's slide, this part of it, where they're saying that by 2018, they're expecting that when you combine the alternative payment models and the fee-for-service payments that are linked to quality, 90%. So that's just how many years away from now? We're in 2016. In just 2 years, we're going to go to half of their payments, value-based payments coming from alternative payment models, and 90% of fee-for-service. So that, to me, is saying that we have the incentives are aligning, and as we all know, that the commercials are following suit in some markets. Next slide. So backing up a little bit, wanting to talk about why it's important to understand the need for a roadmap to value-based care, and to think again about the question we asked about where you are on that continuum or on that graph about risk transformation and clinical transformation. Another way to think about that is to look at this chart on the screen now. We at Phitel and IBM Watson Health, we have done a lot of work with health systems at all stages of this transformation. And in the beginning, 5 years ago, when we first started doing population health readiness assessments and thinking about this, what was in these boxes looked very different. However, there's still the sense that even though today many people have a much more confirmed and specific strategy around moving from volume to value, their financial incentives are, there's definitely more on the plate that is value-based, just like that chart I just showed, because Medicare is moving that way. There's more people participating in MSSPs and commercial contracts, but the tipping point between volume and value-based revenue in any given system might not have totally shifted, and that's something we need to keep in mind. The PHM infrastructure, the population health management infrastructure that exists in an organization, tends to be focused still on things that are happening inside the walls, inside the practices of a primary care organization or inside hospitals. But there's still a lot of work to do to expand how analytics can be used, how to integrate data, how to, I mean, we all know interoperability is still a huge challenge. And even though we talk a lot about the medical neighborhood, if you think about some of the patient-centered medical home requirements to be able to catch and receive referrals and know that they've been completed, we know that that's not easy to do. Certainly not using efficient technology the way we envision it in the future. So some of these things are still roadblocks, if you will, to our roadmap being achieved. But the biggest aha that we come up with is that the people who are on the front line, the people who are the care managers, the people who are the physicians, the health coaches, the social workers, the behavioral health experts, the quality managers, there's still a lot of room to help those who are on the front line to be able to take action effectively, quickly, readily, on a timely basis in order to manage patients for whom their organization is accountable as part of a value-based payment model. It's moving. There's definitely a lot of emerging best practices, and there's evidence coming out all the time about how the patient-centered medical home model is working, and team-based care is very important, but there's a lot of work to do there as well. So as you think about your readiness for clinical transformation and taking on risk, or how far you are on clinical transformation and readiness for risk, think again as you look at boxes like these and how would you fill them out for yourselves. Next slide. I mentioned before that we would come back to the idea of how quickly the financial incentives are changing and aligning with value-based care and value-based payment. It's definitely a roller coaster ride. One of our clients actually created this graphic for us and used it at one of our conferences, and he kindly gave me permission to reuse it. And it really tells the story quite well. While we may think that we are moving from pure fee-for-service to pure value, the truth is we're all going to spend a lot of time on this tightrope between fee-for-service and population management or value-based contracts, because markets don't move all at once. As we were acknowledging before, we have many organizations that haven't hit that tipping point, although they have some and they're getting their feet wet. And so maybe some of you who said that you are already far along on risk transformation and clinical transformation and ready to go, maybe you live in markets and you work in markets where most of your contracts really are value-based. So we have clients in certain parts of the country that are experiencing that, but that is not necessarily how it is everywhere. And it's important to think about how you're going to stay afloat, literally, as you transition from fee-for-service to value, recognizing that you may not ever get fully on the other side and may have to continue to stay balanced in the middle as you move forward. Next slide. So we thought it was good to just show this slide that one of the roadmaps to success, roadmap elements, if you will, is to manage that transition, that tightrope. So how do you do that? You have to look for every source to increase revenue and every opportunity to decrease costs without compromising what you're trying to achieve, which is the triple aim, or indeed the quadruple aim, taking into account provider satisfaction as well. So we've done webinars on many of these topics in particular, but you can imagine that fee-for-service visits to close care gaps, that's something that's very important. So automated outreach to drive individuals into get the services they need to get a billable visit in and billable tests is really important, because one, you're getting revenue in that's appropriate, and you are also closing care gaps. The Medicare chronic condition management fee is something that many of our clients are using quite successfully, and that also helps to provide revenue to do the work that you need to do, not just to do the right thing for your patients, but also to coordinate their care effectively. Patient-centered medical home and other population health management incentives that are coming into play with certain payers. Many payers provide a member per month fee or some other kind of incentive to transform care. Hold on to that thought, because that's going to become even more pronounced, we expect, in the macro legislation. And then you can see too the Medicare value payments to physicians. That's going to continue also through MACRA. And then other organizations are using things like worksite clinics and other ways to support their communities and their local employers, and also drive more revenue and stickiness with their patients. On the cost side, we all know painfully in some cases about the need to avoid avoidable admissions and readmissions. That is a great way to save money. Bundled payments are coming in strong, starting with joint replacement and some around episodes related to chronic condition hospitalizations. Something to think about. Many of you, I'm sure, are in the Medicare shared savings programs, and there'll be many more types of alternative payment models that are going to require you to be successful if you're focused on savings, to think about how to optimally deliver care. And then don't forget your own employees as health systems, managing your own self-insured risk. Doing that as if it is a population you're managing just like any other. Think about that as a risk contract and do that really well. And then, of course, leaning out waste. So I've spent quite a bit of time on this, but each of these are really important, and the lessons learned from using any of these on either side of this table will truly help your progression on that initial slide that I showed you with risk transformation and clinical transformation on the axes. Next slide. So this slide is one we've used for a long time, but I find it still helpful as a visual. And it's good to think about this as we talk about the reality of changing how we manage populations and patient care in a value-based environment. So the traditional side, the fee-for-service side, we think about a population largely as just the people who come in to visit us, or the people who come into the hospital, or the people who come in for preventive screenings or anything like that. And that is a very different model than this slide on the picture on the right of an entire population, and thinking about what is it that we need to know about everybody there, even if they don't come in to see us. If we are responsible for them in a value-based contract, we need to find ways to know who they are, to understand what they need, and to be able to engage them. A very, very different scenario. Something to keep in mind as we continue talking. Next slide. So again, keeping in mind that last slide and the picture of that entire population that I affectionately call the Where's Waldo picture, the new questions that value-based care creates are very real. What is the risk profile of my population? How am I doing on cost and quality? Who are the patients that are not just my current high-risk patients and high-cost ones, but who is likely to become high-risk? And then thinking about patients who may not yet have chronic conditions that are fully blown, but who might be at risk for developing them, and what can I do to mitigate that risk for them and for our population-based contracts? How do I manage them? Who do I talk to? How do I communicate with them? How do I work with them even when they don't come in for visits? How do we help them manage themselves better? And how do we optimize the payment that we can get for the performance that we are required to turn in order to succeed under value-based contract? I'm sure you all have these questions and many more, but these typify what you're thinking about or should be thinking about under value-based care versus fee-for-service care. Next slide. I like to keep coming back and showing different visuals about what it means to do value-based care and what it means to do population health and what people on the front line need, because there are so many different perspectives that have to be considered in an organization as you make that transition wholesale from volume to value. So this is a slide where the message is that everything starts with the data. If you don't have data, you can't change anything. You need data that people trust, that tells you how you're doing performance-wise, that tells you how you are engaging with patients. It tells you how you could improve. That when you have information, when you have reports, when you have analytics that people trust, then you can start developing that line of sight. You can really share with people how they are doing, whether it's patients or whether it's care teams or whether it's physicians or whether it's chief financial officers. And then with that information, just like anything else, you can make informed decisions about how to move ahead. So if you're a care team and you are trying to figure out how to manage your population of high-risk diabetics, you need to know how many diabetics you have, and you need to be able to trust that information, and you need to know what's going on with those diabetics and how many other conditions they have and where they've been and where what their historical costs have been, as well as and probably more importantly what these patients are struggling with today. Is it because they have more conditions? Is it because they have financial issues? Is it because they live in food deserts? Is it because they're, the benefits that they are getting from their employers aren't being maximized? There are lots of things. Do they have a behavioral health issue going on as well that's inhibiting them from being able to take care of their medical issues? That knowing all of that information not just enables but empowers care teams to engage patients. And it is our view that the only way to get to the top of this pyramid of quality improvement and continuous quality improvement, that is highly related, of course, to the AAA, that you need all of that kind of information to engage patients. And really, this is about population health, one patient at a time. And to do that, we are unabashed about saying this, and that you need technology. We all have it, whether it's an EMR, whether it is analytics, patient engagement tools, portals, an HIE, and coming soon more mobile devices and applications, remote monitoring, all those things that were implied in that picture that I showed you of the 24/7 person-centered community. Those all come to play here as well. So this is a very important idea, this bottom-up model that starts with data integrity and the information you need, which is very different than the information you needed to manage in a fee-for-service world. Next slide. I'm sure, too, that many of you work in organizations or in other organizations that have utilized Lean or Lean Six Sigma or some process improvement methodology. One of the things that I love about that methodology is that it doesn't assume, for example, that technology can do it all, or that people can do it all, or that process improvement is something that can be done without considering things like people and technology. So it is, how can you bring all of those things together? And the lessons learned that I'm going to talk to you about from two different clients operating in very different markets, I'm going to share with you examples of how this Venn diagram really must be kept at the forefront to help you manage the transition to value. Very important when you're thinking about doing wholesale, major transformational change in organizations that for decades have been doing something one way, and now we're being asked to do a 180 to do something very, very different. Next slide. So we want to talk a little bit about the future and thinking again about the different types of HIT, health information technology, and why it's fundamental, and why we focus so much on care teams, what I call them the front line. They're the ones in the new world of value-based care that are really going to be changing patient behavior one patient at a time. So what do they need? They need, if you think about the current state, what they have and what they're going to need in the future, this is, again, very much linked to that community slide I showed you at the beginning. So think about this, going from PCP-led team and thinking about being a full patient-centered team that has a lot of different capabilities and competencies and types of team members that can work with patients 24/7 through many, many different channels. And the analytics are much more sophisticated going forward in the future, even including this, the softer stuff, if you will, what people like and dislike, what else is going on in their lives, what they're ready for, how they're ready for it, how they like to learn. Anticipating what people need, not just reacting to what they didn't get. Team activity, being able to work in teams is very, very important, and for managing populations, not just inside of a visit. People, I think, have optimized visits very, very well, but now how do we do it outside of a visit, or all told in a longitudinal way across sites of care, something that is very new and very important in a value-based incentive structure. And workflows. How, again, I mentioned this a bit before, but how do we go from clinical decision support tools within the workflows that are largely around managing the clinical aspects of an individual and a population to really broadening that to have a bigger impact on what hinders people from doing the right thing, if you want to call it that, to being able to work across sites of care in these workflows and really help manage patients holistically as people as opposed to just patients, and having that information be not just automated and actionable, but again anticipating and even predicting what people are going to need rather than just waiting for them to show up sick. A big difference. Next slide. The reason that I talk so much about what we have to think about in changing patient behavior and why it's so important to understand what's going on with every person in your population is because, in fact, most of what makes up our health is related to things that aren't about our genes or even about our clinical conditions. So much is predetermined, or it is influenced very heavily by behavioral, socioeconomic, and environmental factors. So any of you on this call could think about what's going on in your own lives and understand that very quickly, which is why things like the exogenous data is what we call it, from things, everything from remote monitors to Fitbits to any other type of information that we can get about individuals will help us help them. And that is something that we really have to think about in the future of population health management and value-based care. Next slide. So in a nutshell, we really are thinking about how do you organize your operations as health systems and as clinically integrated networks around managing a population such that you have the data, you can know what every person needs at any given point in time, you can automate your activities as much as possible down to the level of an individual, you empower your teams, and you continuously have the ability to intervene, support, engage patients, and help them achieve their plans, their one person at a time to achieve your larger goals. That's what we think is the vision for what population health management will look like. Next slide. So going back to that graphic I showed you at the very beginning that we asked you to plot yourself on as an organization, we broke this down a bit so you can think about some of the things that are involved in the transforming the process of transforming your ability to take on risk and your ability to manage care. And we're going to switch now into the experience that two of our clients had in this journey so far over the last several years, and I'll share with you their lessons and what they would recommend as the core principles or pillars of population health management. Next slide. The only item on this list that is in order of priority is the first one. This is the biggest message that came out at our IHI workshop, and that was that leadership and culture and more leadership and more culture change. Those are the biggest things that really make the biggest difference, because you can't get anywhere without it. You might be able to try to do some of these other things on this list of pillars for population health management, but it was agreed not just by our clients who were leading the session with me, but with our participants. All the stories they told had to do with, or had some aspect to them about how important it was to change culture, or what happened when leadership didn't stay the course, or when there were challenges in changing culture in certain pockets of the organization, or even overall. So something to take very seriously and not easy to do, and we talk about it a lot, and it refers as well to that people circle that was on that Venn diagram I showed you a few slides ago. So we're going to talk about it, and I'll tell you the lessons learned from our clients, but something not to underestimate. My guess is that you don't underestimate it when you think about it, but actually doing it in practice, it's not easy. And then here are the others, and we're going to go through them from the vantage point of two clients' perspectives in just a moment. So next slide. So the two clients that presented with me at IHI, one was Orlando Health, and another is Northeast Georgia Diagnostic Clinic. Orlando Health is in Florida, and they have several years of experience, very positive, successful experience in 2 MSSP contracts, as well as commercial value-based contracts. And they have taken on clinical integration and have had outstanding results over the last few years. Northeast Georgia Diagnostic Clinic is not associated with a hospital. It is a multi-specialty group practice. They do not have MSSP contracts at this point. They have gone down the path of being a patient-centered medical home, and they are anticipating more value-based contracts. They have a high percentage of Medicare fee-for-service patients and are using incentives at their disposal, like the Medicare chronic care management fee, to not just improve patient care, but to bring in that associated revenue and prepare for what they anticipate will be more value-based contracts. So I purposely chose, not just for this webinar, but for that workshop, clients who come at this from a different perspective, and it was quite interesting to hear that the 6 pillars that I just showed you are the ones that they agreed on as we prepared to do the workshop. So these lessons, I think, are quite representative, and I look forward to hearing your comments and questions about it later on. So from a culture perspective, next slide, I'm going to now show you one slide from Orlando and one from Northeast Georgia for each of these pillars as a way to give you some examples of how they handled it and what they're doing. So Orlando really takes culture very, very seriously, and you'll see Northeast Georgia does as well, but the point I'm trying to make is that this was a very significant effort. They still do a lot of work in this area. It doesn't stop. So think about that. Think about that from how you communicate, but to patients, to your internal constituencies, to your markets, to your payers, to the clinical and non-clinical people in your organizations, the message is, this is who we are and this is where we're going. Next slide. This slide often gets a chuckle because it really resonates. And the idea that culture eats strategy for breakfast, operational excellence for lunch, and everything else for dinner might make you chuckle as well, but not necessarily because it's funny, but because it's true. If you don't have executives and leaders everywhere in the organization from top to bottom who are helping to keep the ball rolling, it is very, very difficult to achieve your goals. So take these lessons very seriously and recognize it takes a long time to change a culture. Think about how long the culture for value, how long and how much that was supported and how many decades that has been going on. So to talk about trying to change this in a short amount of time is really not realistic. So you have to be thinking about how you're going to do it and identify your leaders early on and keep reinforcing those messages. Next slide. Shifting into the second pillar, governance, operational, and financial models. Of course, there's so much represented on this slide. What we're saying here is that it's important to make sure that you have your incentives aligned, that you take on the right contracts, that you figure out how you're going to manage under these and still engage your providers, have the care that's delivered by the front line be agnostic to all of these contracts so that you can treat everybody the same way and do the best thing clinically and otherwise for your patient populations. So you want as much as possible for everybody's incentives within the organization to be aligned as you are moving forward with these contracts. Next slide. And Northeast Georgia, their take on governance and operational and financial models that support population health and value-based care, similar to what the message was from Orlando, but thinking about how you're going to build from the bottom up, again, thinking about new delivery models that are going to help you change your culture and change your processes, and over time, how you can build those competencies to be successful under these value-based contracts. And as you can see at the top, just like a couple of slides that I showed you at the beginning, that it's ultimately very important to be able to do people-centered primary care as opposed to patient-centered primary care to achieve your goals under any of these value-based models. Next slide. This third pillar is around the care coordination and the continuum of care, and we are noticing, as you can see in this slide for Orlando Health, and you'll see for Northeast Georgia as well, that the notion of care coordination is expanding rapidly. Not that people didn't understand conceptually about this whole continuum, and but now the incentives are there to truly knit all of this together for any given person at any point in time, so you can manage people longitudinally and not just episodically. Very important, and clinical integration implies a lot of that requires technology, that requires information flow, that requires data. It also requires the aligned incentives we talked about in the second pillar about financial incentives and governance. It also requires huge culture change and leadership to be able to keep people who aren't necessarily all employed by the same organization to be able to deliver care to a defined population or populations. Very, very complex, but very important to be able to have shared patient information in near real time, if you can, to be able to integrate and deliver. Next slide. And Northeast Georgia took a similar view, recognizing that they needed to have practice-based population health management, like the patient-centered medical home model, to drive their performance under accountable care. And again, they're not yet taking on MSSPs and others, but they're getting ready to. And their tactic was to be organizing care in their communities for their patients as well as they can to get ready for what they anticipate. They know that to manage, for example, Medicare patients, even if they're still fee-for-service and the chronic care management fee, it was actually designed for this purpose to be able to help the transformation and the learning associated with managing patients more comprehensively and between visits. They're using tools like telehealth in remote areas of Georgia to be able to improve their ability to coordinate care. Next slide. So the next two slides, we're going to be talking about the fourth pillar, data analytics and performance measurement. And if you remember the pyramid that I showed at the beginning that had data integrity at the bottom, this is exactly what I'm talking about. We spend a lot of time at IBM Watson Health working with clients, and for those of you who are our clients that are on the phone, you know we spend a lot of time on making sure that the data are right, making sure that people believe in it, validating it, understanding all the possible sources and challenges of integrating electronic medical record data into our systems with PMS data and with other sources, and generating these types of reports that people trust and then can therefore act on. Similarly, for those of you who are ACOs, you know how challenging that is. Many of the measures that you are judged on as an MSSP aren't necessarily the same measures that you would have handy. You need to go and build new fields to collect that structured data. We had to do that with Orlando Health to give them that line of sight they need to be able to demonstrate those measures, to see how they're doing on them, and then to be able to prove that their performance on those. So very, very important to have that information. Next slide. So Northeast Georgia depicted this pillar in this way as a stair-step approach, thinking about, again, data, insights, decisions, and actions, which kind of mirrors the pyramid I showed you earlier, that in order to take meaningful action, you need to have the data and you need to understand it, and you need to be able to know what each patient and each person is going to need. So very important to be thinking about how you work your data into your workflows to support value-based care and population health management. Next slide. So the next pillar is evidence-based practices. That applies a lot to managing care and preventive screenings and everything that you all know very well. It also might apply to best practices associated with workflows. So we're going to talk about both. This slide from Orlando is making sure that care teams have the information that they need right at hand or teed up for them, whether it's through the electronic medical record or other tools, to help them know what each patient needs across their conditions and to help those patients make the best decisions for their own care and to create those pathways for care teams who are managing patients with multiple chronic conditions or anything going on with them. So using this and standing orders and other tools to drive the consistency that is appropriate regardless of the contract that a particular patient might be associated with is very important for driving your quality initiatives. Next slide. A similar take on this was provided by Northeast Georgia Diagnostic Clinic, was thinking about guidelines that also related to the different types of programs for managing diabetes and heart stroke, and one of the things that they did to beef up their capabilities besides patient-centered medical home was getting recognition for diabetes and heart stroke from NCQA, for example. Again, leveraging standing orders as much as possible, all with the idea of making this part of the fabric of what they do every single day. And I'm sure many of you do this as well, but making sure that it's done consistently, not just within your own organization, but across a whole clinically integrated network where you don't own everybody, and everybody may not be on the exact same platform, is a big challenge. So while we all know often the right thing to do, doing it is much harder given some of the roadblocks that our historical landscape has had that characterize it. And so when you're trying to switch to value, you have a lot more to think about to drive that level of consistency that is intended by evidence-based practices. And then the last one, we've talked about in some ways already, about team-based care and patient engagement, or consumer engagement as Orlando likes to call it now. It really is about the front line. It's not just the people who are delivering the care, but working with those patients and consumers or that are receiving the care and interacting with you over time. So how do you do it? How do you start doing it outside the walls? How do you make the whole experience better? Many organizations, and like Orlando, have taken on patient and family advisory councils very seriously and have integrated them and the feedback from these councils into their daily work and how they deliver care. Orlando Health, if you Google them, you might find it if you haven't seen it, but they've done great work with shared medical appointments and even got on TV. That's not the bottom slide here, that's something else. But the shared medical appointments, the local Orlando affiliate of one of the major networks did a big piece on this and how great a way that was to keep patients moving ahead, managing their disease, their diabetes and other conditions by being able to share that experience with other patients. Did a whole lot of good on a whole lot of fronts. And then being able to use new technologies like telehealth to manage people between visits and or when they can't come in for a visit. Finding that these tools are very effective, and they've been actually using these tools for quite a while. So these things help teams, they help reach more patients, they help engage people more, and are new types of things that there's finally funding for and support for in various formats to help you in not just accomplish the goals of your value-based contracts, but to manage that transition from volume to value as well. And the last slide is one that actually Northeast Georgia created with a slide that we had originally used as a stock slide for quite a while. They added this putting making HIT a member of the care team, as you can see on the far left, because their view is, and I think Orlando would certainly agree, and many of you might too, that without technology, and technology in many, many forms, some we have become quite used to and some that are novel, are going to be really important for empowering all of these care team members and creating those high-performing teams that work at the top of their license or top of their skill set in order to manage the daily workflows, in order to identify and manage cohorts of patients outside of the walls of the organization, and to really make the triple aim and the quadruple aim come to life. Next slide. So here are 3 take-home messages to think about, regardless of where you placed yourself on the grid at the beginning of our conversation today. So a universal roadmap is definitely emerging, not just based on the experience of these 2 clients, but if you think about your own experiences and the case studies that are coming out and the experience of clients like Orlando Health and Northeast Georgia Diagnostic Clinic, it is that people are starting to figure this out, that the idea that of putting people in the position to take on these new challenges of value-based care and aligning incentives is working. I've said this, I think, probably too much, but it can't be underestimated, and that is culture and leadership are very, very critical. And it happens at every level of the organization every single day, because sometimes it's going to be easy to feel like this isn't worth it, or it's too hard, or people, you have changes in leadership, but it's still very, very important to stay the course and keep your eye on that long-term objective of driving the triple aim and the quadruple aim. And this is an interesting thing, too, that I want to leave you with, is that technology is a big enabler. There's no question that technology is part of every pillar we talked about, and even culture. I would maintain that without the data, for example, to know how you're doing, it's impossible to be a good leader. It's impossible to drive culture change without the information to know how you are performing, how you could do better, where you need to do better, and to be able to celebrate your successes as well. So I want to leave you on that note before we go into the questions.
At this time, you can submit questions using the question box located near the bottom of the control panel. We will take time to answer as many questions as we can. We'll take a few minutes for the questions to start coming through the queue.
Okay, so we have one question here. Our biggest frustration has been finding IT tools that are able to retrieve data, especially across multiple EMRs. How do we handle this? Well, for those of you on the call who work with us already and you have multiple EMRs, you know that we can handle that. It is very important to be able to have a single view of your whole population, and if your population spans practices and organizations that use different EMRs, it's very important to be able to integrate those, and so that's something that Watson Health can do, and that is something that you can think about. Let's see. Here's a really good question. How are these organizations engaging leadership and changing culture? Are incentives involved, or do they rely on champions? What a great question. It is absolutely both of those things. It is not easy to change just by the culture of a strong personality, but leaders at the top are very important. They have to have a mission. They have to have a strategy. And they have to be believable, and they have to have that credibility in the organization that they can lead the change that's required. But it's not about one person or one C-suite. It is about the idea of having champions at every level of an organization. Just a very simple example, if any of your organizations have wellness programs, for your own employees, for example, think about whether you have champions in all your organizations in each department who helps with internal change and internal cheerleading, if you will, to get people to participate in wellness programs. Then just take that up a notch and think about how you would do that for population health and for keeping at continuous quality improvement and changing or developing new workflows. But the champions all look to the leader, the leaders of the organization, both formal and informal, to drive that change. It takes time and it takes patience, but it's critical to have people throughout the organization at all levels have that, I'll use this term again, the line of sight, the data and the information and the belief and the commitment to transform in order to do it. But I won't minimize the fact that payment has to change, not just for the organization as a whole, but it's very important for physician payment to change, for care teams to be paid, to people to understand that how they're going to be paid reflects the values and the incentives of the organization. So that's a bit of a long answer, but very, very important to think about every factor that you mentioned in transforming culture. Think about, just one last thought on that, think about how fee-for-service became so embedded. It's because the financial incentives really drove it and supported it, and now it's become so entrenched that you see how difficult it is to make that switch to value. Well, I hope it's not too many years before we're looking back and saying that the transformation culturally and incentive-wise for value is becoming as entrenched as fee-for-service was and getting the better results that we're all looking for. Please clarify the triple aim and the quadruple aim. I'll be happy to. The triple aim is something that was developed, as many of you know, by Don Berwick at IHI, or actually when he was at CMS, that talks about 3 goals for population health management. One is being able to control the per capita cost of care. And the second one is to be able to improve the health of populations. And the third is to be able to improve the patient experience. Very important to operate on all cylinders to achieve those 3. The fourth aim is been added, and that is provider satisfaction, because as it turns out, people, not just doctors, but care teams and others who work in healthcare are much happier and more productive and feel better when they are working in an organization that is espousing the triple aim, and their workflows are more efficient and their patients are doing better and they have more information and they are being paid in a way that reflects the work that they do or they want to do. And so that is the notion of the quadruple aim.
Karen, we've ran out of time, so if you submitted questions that we weren't able to get to today, we'll make sure to follow up with you directly.
Oh, thank you. That's right, and there are quite a few more questions, so we will do that. So go ahead. I think you want to close this up for us, Sean.
Yeah, first I'd like to thank you for your time today. I'd also like to thank Karen for her presentation. As a reminder, you will receive a follow-up email that includes this presentation and a link to the recording within 48 hours. Also, please take a second to fill out the brief survey when you log off the webinar. We'd love your feedback on today's presentation. And finally, please join us for our next complimentary webinars. I have both of them listed right here, and if you have any questions, feel free to email us directly. Thank you for your time today. This concludes today's presentation. Goodbye.